Welcome to the Brain People Podcast, a show where four mental health experts team up to bring you practical tools for overcoming mental health challenges. The Brain People don't replace your doctor or therapist, but we will give you some extra tools to help you on your journey. So join us as we fight mental illness, one episode at a time.
Hello, and welcome to the Brain People Podcast. My name is Jonathan Edens. I'm a psychiatric PA, and I am your host today. I am joined today with my co-host, Charinette. Why don't you go ahead and introduce yourself today, Charinette?
Yeah, sure. My name is Charinette Gamboa. I'm a psychiatric nurse practitioner here at Beautiful Minds.
And so this is your first time with us on a podcast today, and I'm sure it won't be her last. Today we have a special topic. We are talking about actually getting off of psychiatric medication and, some of the pros and cons of doing that, some of the potential withdrawal symptoms and a collaborative approach that we'll talk about towards the end that you can have maybe with your psychiatric provider in order to accomplish those goals. So before we jump into it, let's talk about why, I should say, as we jump into it, let's talk about why one might even want to get off psychiatric medication. So, why don't you give me a couple thoughts? Just when I pose that question, when a patient comes in to see you and they're talking about, hey, I'm not really sure I want to continue taking these meds. What are some of the reasons that you hear?
Some of the reasons I hear is mostly the side effects of the medications that they don't like, if it's an antidepressant, the weight gain, the sexual dysfunction, and also if it's like a mood stabilizer, sometimes to them it's just very sedating. So they don't like the effect. And for adolescents that I see, they don't like that they lose their personality, like the flat affect of antidepressant medications. And then another reason why they choose to get off of it is they feel like they're doing already better. So they feel like it's not necessarily needed. And they're doing other lifestyle interventions that have helped them.
Before we move on to that aspect, I think it's important that maybe we sort of round out the discussion about side effects.
Yeah, sure.
Antidepressants definitely are one of the most commonly prescribed medications that we use in psychiatry, and generally speaking, relative to many of the other classes, they are pretty well tolerated by most people. But sometimes these minor annoyances that they do have over long periods of time can really become increasingly, progressively, more major, right, towards the patient. And some of the things like you mentioned, long-term, like weight gain and sexual dysfunction, those tend to be some of the most common complaints that I see with long-term use. And then, with other medications, outside of the antidepressants, there tend to be some more serious side effects in the long term. That tends to be a very good reason for why we might change. So things like antipsychotic medication, or sometimes called the mood stabilizers. What are some complaints that you hear with those classes of meds?
So for some of them, like just recently, a patient said that when taking Risperdal, she started chewing her lip all of a sudden. Some of them, even with antidepressant, it can lead, if we don't really know what their true diagnosis is, can even lead to mania. Sure. Right. So that to them is like, oh, well, with the Wellbutrin, I guess one patient was telling me like, I did not like how it made me feel. I had this euphoric state and I felt like I wasn't myself and I was going crazy. Yeah. So that's the one that I've seen commonly. So,
yeah, I've had that happen too with Wellbutrin. A patient that had no history of mania did end up, I triggered a mania even with like the lowest dose, to where he didn't sleep for a couple days in a row. And so while those are, relatively rare, reactions to some of those medications, they're definitely a very good reason to withdraw. Now, when it comes to, bipolar medications or antipsychotic medications, it depends on the drug, but, as sort of a general class, there's really two I should say there's two very worrisome long-term consequences of those meds. The first one is metabolic problems. So, weight gain with antidepressants generally tends to be relatively mild, but can be a problem, especially after years of taking it. But with some of the antipsychotics, weight gain can be very rapid. And so, top of mind, olanzapine, right? Risperidone, Seroquel, like these drugs, I've had patients put on 20, 30 pounds, within a span of 3 months. So that's a really big one. And then what's another really significant long-term, side effect of the antipsychotics that you see?
Actually, the one that I saw the worst was this patient was put on Haldol and she had Parkinsonism. So EPS, extrapyramidal symptoms as well. And literally she was like shuffling the gait. She had the facey, masked. And I was like, I thought she had a stroke.
Sure.
Honestly. And then when I looked over her history, she was put on Haldol. It was a higher dose and we had to stop that immediately.
So she mentioned EPS, extrapyramidal symptoms, which is basically a fancy word for a series of side effects associated with this class of medications that cause involuntary muscle movements.
Right.
And so that could be, sometimes it's a tremor of the hand. It might be smacking of the lips. Could be just your tongue moving inside your mouth. Could be constant shifting right in your seat or feeling very restless. And so these, especially over the course of time, they generally tend to be progressive, right? They get worse and worse and worse, and without actually removing the medication or using something else to mitigate the symptoms, they can become extraordinarily distressing to the people that experience them. Now, another class of medications that are frequently discussed for patients weaning off of them is the benzodiazepines and the Z drugs. So why might some patients in your experience want to get off of this class or these classes of medications?
Some of them have complained like fogginess, memory impairment. Those are the main things. And I think realizing too, I had one person said that it was so sedating that it was hard for them to even function throughout the day.
Yeah.
So even though they took it at night,
Yeah.
So.
Yeah. These medications really suppress your nervous system, right? And so they tend to make it hard to think. They tend to put you to sleep a lot of times. And so a lot of people do complain about those things, and especially the longer they've been on them, there does tend to be a noticeable increase in risk of memory, chronic memory impairment, and dementia. In all honesty, what are some of the reasons why providers want the patients to get off of that class of medications?
Very addicting.
Yeah.
So dependent.
Yeah. So exactly. Dependence can be, especially physiological dependence to a certain extent, can be present in just about every class of medication, not just in psychiatric medications, but psychological dependence and addiction are a big problem with the benzodiazepines in particular. So that would include meds like Xanax and Ativan, Valium, Klonopin. Some other things, at least with the Z drugs, and this, this is somewhat well known because there's been, a number of, I think there was, I forget the name of the individual, but they ended up dying as a result of this particular side effect. I believe back in like maybe the 90s or early 2000s. Wow. From Ambien. Do you know what I'm referring to? Do you know which side effect? The sleepwalking.
The sleepwalking.
Yeah.
Okay.
So I believe it was a relatively famous person. I'm sorry I didn't look this up ahead of time, but I believe they got in their car and they went for a drive while they were still asleep.
Oh no!
And so that is, I've had a number of patients on Ambien specifically, but there are a couple other meds that can do this as well. That found by maybe their family members or when they woke up the following morning that their house was everything was shifted around, that they had been sleepwalking, and that was very concerning to them. And so, they wanted to stop taking that medication. Yeah. So circling back, you mentioned another reason why some people want to get off of psychiatric medication. And you basically said that the medication is, for some reason is maybe no longer needed like it was before. So what are some of the reasons why people might say that they're not really feeling like it's necessary anymore?
Well, I think I said like because of their lifestyle interventions that they've done, like exercising, their sleep has improved, maybe the stressors that they're currently facing at that moment have, subsided. So it's not as severe and intense. So they're able to handle and maybe they've learned coping skills to adapt to those given situations. So that's one of the reasons that they say, I don't think this is no longer needed. Another reason why people want to get off some medications is also that it's no longer working. So that's another.
Yeah.
Probably try something different.
This is maybe a little bit more of a challenging question, but how do you make that determination if a medication is no longer working?
I think for me, I would definitely ask more of their, symptoms before and after, and then if there were any changes that occurred during that process, and then I think I don't know. That's the only reason
it's
kind of hard.
It is. It's incredibly challenging to really make that assessment. But usually my sort of general rule of thumb, if somebody believes the medication is not working, it's they've already probably gone so far that if you're not convinced, there's definitely a placebo effect when it comes to medications. We know that. Right. But there's also part of that placebo effect is belief in that what you're taking is actually doing something. So once you've lost that belief, then really you've lost the game. That's in all honesty. And so generally speaking, I don't really try to, unless there's a really good reason, try to convince people otherwise. And then so as a result, we end up talking about other options. I like what you said about, some like the holistic, individuals adding in sort of more holistic treatments. And as a result, what it sounds like you were saying was that the medication is less necessary over time because they're doing these other things that are also proven to have therapeutic benefit. The image that I tend to have is somewhat of like a pie chart. When you're maybe first starting out with this journey in your mental health and you need more immediate, therapeutic response, like medication might be the bulk of that pie chart. And as you get a little bit better and you build momentum, you start adding in these other layers, right? Like maybe you start focusing on your sleep hygiene. And so you really optimize that. And you start building better relationships. And you get in touch with kind of the spiritual side of yourself, and you start exercising more regularly, right? Yeah. Those things start filling in the pie chart. And so as a result, like the total sort of degree of benefit you're getting from the medication is less so. And there's even research, and I know we've referenced this before in previous episodes, that long-term things like exercise can actually perform a lot of these psychiatric medications. So the longer that you do those holistic things, there's a much greater chance of success of being able to do without. And then there's a couple other things that I think that I hear occasionally from patients in terms of their desires to want to discontinue their psychiatric medication. And one of the things is that their treatment goals have changed. You may have been in a season of life where it just made sense to take the pill. Right? It made sense to take that antidepressant because that was what was most convenient, and that's what worked for you at the time, right? And maybe it was because of time constraints where it would have been very difficult for you to incorporate an exercise routine, right? I've had like new mothers, right, for example, and because of all the time and the lack of sleep that they were getting, it was very difficult for them to incorporate some of the other more holistic things. But then as their child got older, there was more time on their hands, and so they were able to start doing those things again. And so I think that's an important topic that isn't like frequently discussed. Generally my impression has been from a lot of other providers that we sort of assume that like their treatment decisions that they made originally when they came and saw us are going to be somewhat indefinite. They're going to be the same. But we're obviously we're very complex individuals, and our motivations are somewhat in flux frequently. And so I think that's an important component to take into consideration. And then the last thing I'd probably say, and this is just sort of this is a common complaint as well, but just a general desire to reduce overall medication burden. Sometimes we end up getting a little bit overzealous, and so we end up, prescribing more than what we would really like, or over time, right, going back to the treatment goals, the patient was originally comfortable with maybe a certain number of meds that they were on, but now they're really wanting to consolidate and just kind of optimize over time. So that's true. So sometimes people just feel like their medication list is too long, it's too complex. They want more of a simplistic approach, and they believe that that's going to be a better outcome for them. So shifting gears, let's talk a little bit about, the experiences that some people have with withdrawals from these different classes of medications. So, referencing the antidepressants again, the SSRIs, SNRIs, things like Prozac, Lexapro, Zoloft, Effexor, very commonly prescribed medications. What are some of the withdrawal symptoms that you tend to see?
So some of the patients would tell me like flu-like symptoms, right? Headaches, the nausea, just fogginess. So those are the things that they've mentioned. And if it is, more an anxiolytic medication, sometimes they can feel a little bit of the anxiety as well.
Yeah.
As well.
A couple of ones I'd throw in there as well is just mood instability.
Yeah.
As you're going through withdrawal from these medications, just because you do experience mood instability during withdrawal doesn't necessarily mean that the medication was actually supporting your mood. It may be that you're just, your body is sort of trying to adapt to the changes in the physiological sort of chemical changes that are occurring. And then another one that's kind of unique to the antidepressants that people talk about are the brain zaps.
Yeah.
You've heard this one before.
Yeah. Mm-hmm.
Do you, are there any medications that you notice this the most with?
I think probably those short-acting ones, Lexapro or Paxil.
Yeah. So Paxil is really bad for a lot of people. Effexor is particularly bad for a lot of people.
Sure.
Cymbalta, I've gotten a lot of complaints on that. Things like your Prozac, for example, generally doesn't really tend to cause a lot of problems when it comes to that. And so that is definitely a more unique side effect that, really, I think unless you've gotten off an antidepressant, you may not really ever understand what that means. So mood stabilizers like bipolar medication. What do you think in terms of some withdrawal effects that you've been told?
I think it's more mood swings.
Yeah.
Like just the effects of the drug, because we have to understand the body always wants to be in a state of homeostasis. So when you're putting some things in your body, right, the body then adapts to be like, okay, I'm not going to produce this much because I want the brain to be in that state of homeostasis. But then when you're removing it, the body's now trying to figure out, okay, how can I compensate for this because I'm losing this?
Yeah.
So yeah.
So it depends. Once again, it's going to depend because the mood stabilizer class has really quite some variety in it.
True.
But things like just feeling overly activated, feeling restless, feeling irritable, not being able to sleep very well. As you mentioned, like the more intense mood swings is pretty common. Things like dizziness as well can be relatively common. Anything else you wanted to add there to the mood stabilizers? Oh, I guess even seizures, right?
Yeah, that's
especially
true.
if it's Depakote, Lamictal, Trileptal. These medications, they are seizure medications, and so if you were to withdraw from them very quickly, even if you don't have a seizure disorder, like your body in adjusting to that equilibrium, like you said, could potentially result in a seizure. And then benzodiazepines. So what sort of withdrawal symptoms have you seen?
The most lethal one, I mean, I haven't seen it, but just knowing about it is more seizures, right? Actually, I think the patient of mine, was sent to the hospital.
Okay.
As a result of it.
Yeah. Seizures can definitely be a really scary, severe side effect of withdrawal from benzodiazepines. And because of the habit forming nature of them, it is, important to taper, under the professional, I should say under the care of a professional, right? Because this class of medications can be lethal, like you said. Some of the more common things, especially if it's a relatively low dose that you're trying to get off of, I should say the most common thing is probably just increased anxiety, right? So rebound anxiety, as we would call it, or just having a lot of panic attacks, right? Those can definitely be present as well. So a reduced sort of stress tolerance, an inability to really shut down your brain, right? So a lot more racing thoughts, ruminations, things like that. Some people do get muscle spasms and digestive issues as well, because it tends to have a calming effect on the muscles too. And so when you take that away, the muscles end up getting tight. Digestion doesn't quite go as well as it did. So lots of downsides to withdrawal as well. So I mean, with all the withdrawal symptoms, right, that we've talked about, so we probably scared you a little bit about taking the med. We've also probably scared you a little bit about getting off the medication. But let's talk a little bit about how to get off these meds. And I know we have kind of a specific sort of a collaborative approach that we'll talk about here in a second. But one thing we really want to emphasize is don't try to play doctor. Even though you may be a really knowledgeable, individual about your medication and you've been compliant. Some of these medications, it really just depends. And, your provider is going to have a lot more experience in terms of helping you minimize the downsides of getting off, right? If you resonated with one of those reasons to get off, then we want you to be successful. Right. And I've had so many people that have tried to do it on their own and they weren't able to be successful because they didn't do it in a way that was really safe.
Exactly. And I know some patients have done it like just cold turkey. And as a result of that, they go back to the drug because they didn't like the effects of that cold turkey effect, right? So
and I would say there's been a lot of instances where patients do exactly what you just said. They try to do it themselves, and then the withdrawals are so bad that they become actually more convinced that they never want to get off of it.
Exactly.
Right, and so it's a negative reinforcement in a sense, and so if they had just maybe done it in a much safer, more conservative approach, then they may not have made it worse on themselves or shot themselves in the foot, so to speak. So, basically put another way, recommendations for withdrawal are extremely dependent on a variety of factors. It can depend on the medication itself, the individual's sensitivity and risks associated with withdrawal, the patient's desired time frame to being, without that medication, and whether or not you're adding a replacement medication or supplement to kind of fill in the gaps of the symptoms that you're trying to treat. Yeah, exactly. And that is like that in and of itself could be its own podcast, just talking about like what things that you can do. But as a basic sort of example, like in my experience, like I've used a lot of Prozac to help people get off of medications like Paxil or Effexor, and that's tended to work pretty well. I've also used a lot of different calming herbs or kind of mood stabilizer medications or antidepressant. Excuse me, I said medications, I meant supplements, or antidepressant like supplements, right? To help to mitigate some of those withdrawal effects.
Yeah, I've used, for example, if I'm trying to taper someone off of benzo, definitely using gabapentin to make sure, because of the seizure withdrawal effect, to kind of help buffer that as well.
Yeah,
and
absolutely.
I've used even our mindfulness relaxation supplement to slowly get them off, So,
awesome. The last thing we wanted to talk about today was the patient-centered collaborative approach. So basically, I'll have Charinette kind of explain this in detail, but essentially, it's an approach to collaborate, as the name implies, with your provider, and hopefully, you are working with a provider that agrees with a lot of these principles, because in doing so, I think you're going to have a much better experience in tapering off. So, Charinette, why don't you take the mic and tell us what the patient-centered collaborative approach is?
Yeah. So the patient-centered collaborative approach doesn't only include the provider and the patient, but it also includes the therapist and the family support, because it's really important that when you're trying to help a patient get off a medication, that they have all the support that they can get. And what I like about this approach, it provides honest communication, empathy for the patient and the family, and also it provides the ability for the patient to make the decision themselves. So empowerment, right? Because that's where it lies. If you can empower the patient to make that decision that it's okay to slowly get off these drugs as they're seeing more results on either their lifestyle interventions or their goals have shifted, then you give them that comfort and they don't feel anxious that you're in control. It's actually giving them that control. And I think when I talk to my patients about like we're going at your pace, at what you would like, and I'm not going to try to hurry you. That calms them down and gives them a sense of comfort and security that you're hearing them out. So actually, Dr. Peter Bregan was the one that actually started this patient-centered collaborative approach. And his main goal was to safely get the patients off the medication, but making sure that he's able to talk them through it along with their family, along with the therapist. Because once you take them off, you'll, like we said earlier, they'll have like mood swings or probably more cognitive distortions that they're thinking or racing thoughts. That's where therapy comes into play and helping address that. So, that's what I like here too, working here at Beautiful Minds, is that we're able to talk with the therapist and figure out, okay, what can we do to help support this patient as I slowly get them off, I wish we can have that as, the medical world can do that. That would be really nice to be able to communicate instead of just doing things independently of each other.
Sure.
I think that's where patients lose their trust towards providers, because things are happening independent and then not including them in it, which is really very important to make sure that they have that control and empowerment in doing that. So
what are some of the steps of the approach?
Okay. So the steps first is finding out what their, comfort level is and the pace they would like. If they want to do it immediately, then you can, cater to that. If slowly, right? And usually understanding what their sensitivity level is and withdrawing them from the medications. So there are times that I've done it for a long period, right, based on the patient's comfort, but also short because the patient just doesn't like it anymore anyway, right? So that's the first step, being able to understand the patient's comfort level, understanding too that are they having that support at home, and then do they have a therapist? That's really important. If they're seeking therapy, because when you remove something from someone, right, you want to replace it with something better. So the next one is making sure that you also start in small dosage reduction, because even just a 10% reduction of the drug can definitely put a patient on a severe withdrawal and a severe adverse effect from that. The next one is providing them detailed information of what they're going to experience, so that it's a full disclosure, so that they're not left hanging. So making sure that providing them as much education, and then what they can do, like you were saying earlier, maybe supplementing to help buffer that withdrawal effect for it not to be so potent.
Mm-hmm.
And let's see, at all times to actually provide that hope and encouragement throughout the process. And there are some patients that have told me, you know what, we've gone lower. I can only handle this much. Let's stop reducing it. And I would say, yeah, that's no problem. And so whenever you're ready, again, we can start doing it again. So just kind of adapting to the situation.
I really like that. And I feel kind of silly for not having discussed that sort of previously in terms of getting off of medication. The goal doesn't always have to be to get off, right? The goal can be to see if you can reduce the dose or the number, right. and as a result, maybe get very similar treatment effects from lower dose. Frequently, I have patients that may be able to reduce their medication dose by half, and yet they're still getting 80 to 90% of the benefit of the higher dose. And so now, they're looking at that difference and they're saying, hey, yeah, that's totally worth it to me.
Right. And so I think what I really am learning more and more is being able to be an active listener for my patient and advocate for them, and being able to understand, okay, if I were in their situation, and my life, I can say, is at your hand, right? At your disposal, there's a sense of instability there. And so that therapeutic alliance needs to be, built, and trust needs to be continue to grow as a result. So if I don't hear them out in what they're, sharing and complaining about, then the trust is broken. So then they'll be more likely to stay on that drug than not. So.
Yeah, I think that that element of them knowing that we care, right? Showing them that we empathize with them, like you said, being in their shoes. I mean, it's so huge. And if you can demonstrate that, I mean, I've had many conversations where I, feel compelled to bring up the benzodiazepine conversation, right? And initially they're very defensive. They basically think that I'm, out to get them, that I'm taking away the things that help. And, with careful consideration of what I say and how I go about it, I feel that I'm, usually pretty successful at convincing them, and where frequently a lot of times they're actually more passionate now about getting off the medication than I was, right? Because they see that, that it's, in many cases, sometimes it can be a trap, right? And that it's, maybe they're at a different point in their life where this is not really serving them in the way that it was at once, at one point, right? And so that empathy, that compassion, just that, that having that human element just goes so far in making this approach, I think, easier for people. Any other points for the approach?
I don't know if this is in addition to this approach, but what you were saying earlier, that not being reluctant in educating the patient about, the adverse effects of these drugs, and your willingness to, and maybe in the future, tapering them off. That's what I've done, is just more education and realizing, hey, just want you to know these are the adverse effects long-term. We're not trying to discontinue it now, but whenever you're ready, whenever you're comfortable, maybe sometime in the future, you can consider that. That to me, I feel like with the patients, they've actually, like you said, we're more open. One patient in particular came to me, already decided to get off the medication, but she was afraid of how I would react, because she's been to psychiatric providers where, no, you need to stay on this, or other primary, nope, you have to stay on this. You have this long-term, right, disease or whatever. And so when I said to her, oh, wow, that's great. I'm so glad. She was like, are you serious right now? I was like, no, are you serious? You really want to get off? And so sure enough, she was just so happy. She was like, you made my day, she told me. And I was like, well, no, you made my day, right? So it was really a blessing to be able to have that conversation with her. And she felt so relieved that I'm not there to just stick her on that drug. I'm willing to hear her out. And she actually was able to taper off slowly as a result of that. So
that's awesome.
Yeah.
Thanks for listening. To hear more episodes, find us on social media, or support us financially, visit thebrainpeoplepodcast.com.